Hi everybody, welcome to another video. Today I'll be discussing pulmonary embolism, its diagnosis, as well as management. I'm also going to briefly discuss recent literature in terms of how we understand thrombolysis in terms of classifying management for patients with submassive or massive PE. Before I begin, I want to give a small disclaimer letting you all know that the information you'll hear is purely my own way of thinking about this topic. It does not reflect a strong recommendation that you guys should follow blindly. You should all interpret the data by yourselves, and you should always communicate to your attendings before you employ any of the information that I'll provide. So to start, pulmonary embolism, as you all remember, is an obstruction essentially of the pulmonary arteries or one of its branches. It could be due to many different causes, from thrombus, thromboembolic events, tumors. It could be an air embolism, or it could be a fatty embolism after trauma. The nomenclature for PE is classified by either acute, subacute, or chronic. That has to do with the timing of it. In terms of another classification that I think will be really important in understanding the management of it is being able to understand what massive, submassive, and low-risk PE are. So massive PE is really any PE that's causing hemodynamic instability, as defined as a systolic blood pressure of less than 90 or a drop in systolic blood pressure of greater than 40 from the baseline for a period of greater than 15 minutes, or any hypotension that requires vasopressor or inotropic support that is not explained by any other etiologies of shock. So this is purely an obstructive shock etiology, not cardiogenic, not septic in nature. And so that's massive. For submassive, there's actually two categories. There's submassive with high-risk features. There's also submassive with patients with low-risk features. And I'll be discussing both of those briefly. There's also patients who could have low-risk PE, and those are essentially patients who are stable. They don't have any hemodynamic instability, as well as any other evidence of right heart strain that I'll talk about also in a few minutes. So going back to patients with submassive PEs, these patients are actually patients who have evidence of right heart strain, meaning the pulmonary artery is causing so much pressure that it's causing the right ventricle to bow towards the interventricular septum, causing aortic ejection fraction to be decreased, causing patients to have a form of shock or hypotension. So they do have obstructive shock. So the way that this works is there's an increased right ventricular afterload. Right ventricle dilates. There's a tricuspid valve insufficiency. Then over time, the right ventricle has increased wall tension. Myocardial inflammation occurs. There's a more demand ischemia going on. Eventually, the right ventricle has a decreased contraction because of right ventricular ischemia, hypoxic injury, and over time, there will be a decreased left ventricular preload, and you see the systemic blood pressure that's going to drop as well. Because of this ischemia, you are also going to see evidence of myocardial myocardial markers that are going to be elevated, such as troponin. It's going to be elevated, and that in itself is actually characteristic of high-risk features. Is patients that will have elevated tropes in the setting of right ventricular failure. If patients have purely right ventricular failure without any elevated tropes, those patients meet submassive category, but they're under the category of not high-risk features, so they have low-risk features for that. And I'll go over the management later for that. But then the most important thing that I want to discuss today is submassive, because there's a lot of current data that we don't really know about in terms of what the management is. So I thought it would be interesting for me to and typically a lot of patients that we see are submassive, and it's important for us to know that. So I'll be discussing during this talk more submassive. In general, pulmonary embolism is such a very difficult topic. There's a lot of things, so this is definitely not exhaustive. I'll most likely make another video discussing different trials specifically. So patients with submassive PE, you'll have dilated right ventricles over time. You also have a basal right ventricular to left ventricular ratio that's going to be elevated. And for those patients, you could have something called a McConnell sign, which I'll have here. In a picture, you could see there's right specifically in the apical chamber. You'll have some essentially some hypokinetic activity as well. You should look up. I'll try to provide a video, and I'll have it here for you guys to see. But also, you could have over time, you'll eventually have the intraventricular septum that's going to be bowing down, and also right ventricular tricuspid regurgitation is going to be also increased. So there's a decreased tricuspid annular plane systolic excursion. You could measure it based on the M mode, and basically what it is you're looking at the amplitude of when you press the M mode of from the minimum to maximum, and if the difference between those two is less than 60 millimeters, that's equivalent to around 45% ejection fraction. If it's less than that, it's less than 45% ejection fraction. So it's essentially almost similar to the M mode of a mitral valve and measuring left ventricular ejection fraction, but this time you're measuring right ventricular ejection fraction. So it's a marker to help you see if patients have clinically significant right ventricular ejection right ventricular dysfunction. And that's something that we do at the bedside when patients have suspicion for PE. So the other thing that we wanted to talk about next is kind of the management of these patients. So patients with coming in with massive PE, you'll definitely call IR to help you with the management, but they'll be the ones pushing most. So it's agreed upon that for patients with hemodynamic instability, you'll be doing systemic TPA or catheter-directed TPA. The IR is usually the ones that are going to decide what would be better. Typically, with patients with systemic TPA, there's an increased risk for bleeding, so there has to be a consensus among the patient as well as the provider, letting them know the risks of bleed, intracranial hemorrhages as well. And at that point, we will make the IR and we'll make a decision whether to do systemic or catheter-directed thrombolysis. Really, where the picture is a bit muddy is in patients with submassive PE. There's been recent studies looking at this and being able to figure out exactly what the best management is. And there hasn't really been a large study with high power looking at this. So the consensus is a little bit murky. There's no definitive guideline saying patients with some massive PE with high-risk features should definitely get this. It's all based on clinical judgment, but at the same time, any patient with some massive PE, in my experience, I would be calling IR. I actually brought this up to an ICU attending at a very well-known university. He's well known in pulmonary embolisms, and he did say that the data. There's a couple of trials. There's I'll go over them, but there's a couple of trials, the PETHO as well as the Ultima trial that looked at this, and he said in general you would call IR for some massive PE with high-risk features, meaning right heart strain with elevated markers, and even patients with low-risk features, you can't go wrong with calling IR. In general, the way I like to think about it is I don't know everything, and even though data is there, guidelines might be there, even if they're not, it's always best to get someone who might know more than you, and at that point, there's no harm in calling someone for help. In general, the trial that I'll be discussing now for patients with intermediate risk pulmonary embolism is the PEITHO trial. What this looked at is essentially patients who have submassive PEs, meaning they had a right heart strain as well as elevated cardiac markers like elevated tropes. And the primary outcome for these patients was just hemodynamic decompensation or collapse within 7 days after randomization. So it was a randomized double-blind trial comparing systemic TPA plus heparin with placebo plus heparin. So just patients with either heparin alone or systemic TPA with heparin. And it was 1,000 patients. They split them equally, around 500 to 500. And what they found was the intention. They also did an intention to treat analysis. So even patients who left the study or moved to a different study group, they were still treated within that group that they were originally in. So in terms of the analysis, what they found is that patients death or hemodynamic decompensation occurred in 13 out of 506 patients. That's like 2.6% in the patients with systemic TPA, as compared to only 5.6% in the placebo group. And it was statistically significant, actually, a p-value of 0.02. So that's something that they kind of looked at. But then they also looked at between the randomization and day seven, there was patients who died as well. The 6 patients in the systemic and the placebo, there was around 9, and there was no statistically significant there. But in general, what they found was that patients with systemic TPA prevented hemodynamic decompensation, but it also increased risk of major hemorrhagic bleed. As you can see above, the p-value for hemorrhage was 0.003. And patients who were in the systemic TPA group had a 2.4% of having hemorrhagic strokes, versus patients in the placebo group only 0.2%. So pretty significant hemorrhagic adverse events there. So in terms of so they were not able to relay this data, even though it was implicating that systemic TPA was something that would be useful. The guidelines currently, so the most recent guidelines that I'm aware of looked at kind of at both that trial, and they also looked at the Ultima trial, which looked at patients who were actually getting catheter-directed thrombolysis using more of a fixed dose TPA. So the TPA was actually less than the amount was less than the patients with the other prior trial. And then they also compare that to just use patients with just heparin alone. And these patients were having some SFPs with high risk features. And they found that ultrasound-assisted catheter-directed thrombolysis was a safe procedure when compared to systemic TPA. But the trial, again, wasn't very high-powered. There was only very few patients in the trial. I believe there was about 59 patients that were enrolled, so the power was not significant, and the confidence interval it was pretty wide. So in general, that's something that they still haven't come to a consensus, and that's why it's important for us to be kind of diligent about calling IR, because in the end, we don't know everything. So with that being said, I want to just kind of leave you guys with more information about the different guidelines in terms of kind of how we started coming up with these specific treatment plans. Because I won't have time to talk about each one of them. But in general, the anticoagulation for these patients, you definitely want to start them on heparin, calling IR, and then there was actual evidence also that patients with direct oral anticoagulants, they could prevent venous thrombolism in patients with cancer as well. So we're seeing data now to suggest that apixaban is non-inferior to both low molecular weight heparins as well as Coumadin. And it also has a lower risk of bleeding if you use apixaban, and it is an oral agent, so it will be a lot easier. So there's a data that I'll put in. I won't have time to discuss every little detail, but I think it will be interesting to discuss. So in terms of the other thing before I leave, there's a big discussion about IVC filters. There was a couple studies that I'll be linking, and what they looked at was patients who were getting IVC filters. One of the largest trials to date was called the PREPIC at 1. It basically examined the effectiveness of IV filters. It looked at 400 patients with proximal DVTs. They were all randomly assigned to either standard anticoagulation alone or anticoagulation plus insertion of an IVC filter. And then they randomized it and everything. And then during the first 12 days after they randomized, there were significantly fewer patients in the IVC group that developed a PE. That was 1 versus 5%. But overall, after 2-year follow-up period, there was no significant difference in survival or symptomatic PE. There's another study that they did afterwards, and also kind of found similar results, that there was really no significant difference. And actually, there was more adverse events in terms of having more instant thrombosis or thrombosis of the IVC filters alone, more complications for guide wear, entrapment, local hemorrhages, fractures, embolizations. So for patients, really, currently, at least as far as I know, the only indication for an IVC filter would be patients who have either recurrent thromboembolisms or have a contraindication to anticoagulation. So at least that's as far as I know. I'll keep learning and reading, and I'll update you guys if there's any new different information. But as far as I understand, that's what we know to be an indication. But of course, IR would be someone that would be consulted on for a PE patient, and they would decide whether IVC filter is appropriate for that patient based on other criteria. So that's all the information I'll be able to provide today. Thank you guys. And again, before I leave, I want to let you guys know that in the end, all this information is just for educational purposes. It's based on only my beliefs in terms of how I interpret the data. It does not reflect anyone who I'm associated with, and I urge you guys to do not follow this advice or recommendations because they're not recommendations. They're just sharing my own personal opinion, and I urge you guys to do your own reading before following any of the information that I shared as clinical information. Thank you guys, and I hope you guys have a great day.